Good morning. I'm Fred Leonard, the Executive Director of the Healthy Start Coalition of Métis County, and I welcome you to our June General Membership Meeting. And it's my pleasure to introduce our speaker for today. Dr. Cartaya completed his postgraduate training in pediatrics and neonatology at the Albert Einstein College of Medicine at the Bronx Lebanon Hospital Center in New York. He is board certified by the American Academy of Pediatrics and the Neonatal Perinatal Medicine Board. He is currently Director of Neonatology at Manatee Memorial Hospital. Dr. Cartaya has been the Chairman of Pediatrics at Jackson North Medical Center and Parkway Regional Medical Center in Miami Beach, Florida. He has held numerous appointments at several prestigious hospitals in Maryland and Florida over the years. In addition, he has taught at the Bronx Lebanon Hospital Center, at the Johns Hopkins Medical School, at the University of Miami School of Medicine. Dr. Cartaya is a frequent guest speaker and a lecturer at medical symposiums around the nation. Dr. Cartaya.
Hi. That presentation made me look important. I'm not, okay? I'm not. Listen, let's have this talk as simple as we can and make sure everybody understands, and let's make it interactive. It's actually a simple topic, but it's a big problem. It's epidemic proportions. It really is. As I was reviewing this stuff, I noticed some epidemiological factors that are really striking. It speaks about our society. The CDC reports that 1 American dies every 14 minutes in the United States. That's a big deal, okay? In Florida, in just our state, 7 people die every 24 hours from drug overdose. Unintentional poisoning means the overdose replaces only automobile accidents as a leading cause of death in between the ages 15 to 34. All right? Neonatal abstinence, and this I saw myself. I've seen this over the past 10 years. Over the past 10 years, 10 years ago, you had a baby with neonatal drug withdrawal every few months, if at all. Now there's always 2 or 3 in any neonatal unit. At least, I would say 25% of the base is neonatal drug withdrawal. Okay? Oh, this is an interesting study that they did. There was a national survey done in 2009 where I don't know if they got consent or not, but they basically tested all the pregnant women's urine. They got, the urine got sent for something else, and they tested all the pregnant women's urine, and they found that around 5% of these women during their pregnancy were taking some kind of drugs. And they were not told they were going to do this, so they just walked in to test the urine. So at any given time, around the country in 2009, 4.5% of women were taking some kind of drugs during their pregnancy. Okay, this is, by the way, all these presentation on the bottom, which is probably very hard to read, it has the resource where I pulled this from. Okay, so when you get this presentation, if you're interested in this, this is the list that the American Academy of Pediatrics posted at drugs that potentially can cause withdrawal in babies. It's going to be in the test at the end of the presentation. Nah, just kidding. I just posted it because I figured it was important. It keeps on going, and it keeps on going. I'm going to skip that one. Okay, but what we really see, the majority of the problem is the use of methadone. Methadone is probably our biggest culprit for neonatal drug withdrawal in any given nursery. The second one is Sobunex, believe it or not, although it's at the bottom. It's a more fancy drug that they give the moms for drug withdrawal, but as far as in the baby, it's actually, the nurses would say it's worse than methadone. The studies are out, but it does give you drug withdrawal. Other ones are morphine, cocaine, oxycodones, codeine, and heroin. All these drugs are very different, and we're going to go through each one of these. Go ahead.
Is it Manatee County specifically?
Yep. Yeah.
Wow.
The biggest one is methadone, and Sobunex, by far. I came from Miami about 3 years ago, and we had less prescription, but epidemiologically has changed. I think I haven't worked there in the past 3 years, but we had less prescription drugs. We had more cocaine and other stuff. And what I noticed when I came here was that they were nice-looking people. You would not know. In Miami, we knew who the druggies were. We knew. Okay, here you don't know. There's a nice-looking person that you would never think they were doing drugs during pregnancy, and they are. In Miami, most of the time we knew. Please do that. If you have any questions, ask me, okay? The first one we have is cocaine. I found it interesting, all the names that it has, so I posted it up there. It was a learning experience for me, too. Cocaine does give you a neonatal drug withdrawal. It does. But the drug withdrawal is not that much the problem that it has, as it is the teratogenic effect that it has. What it does really, what it comes down to is it's a very potent vasoconstrictor, which causes the placenta to get smaller from microinfarcts, and as well as the baby's body and brain. So you get a smaller baby with a decreased head circumference, of course, less neurons, and you have more long-term effects of this than the withdrawal. Unlike methadone gives you withdrawal, but doesn't do these things. Cocaine is more of a long-term problem during pregnancy. The withdrawal is not so much the problem. Also, a lot of women, it does give you cerebral palsy and stuff like that. A lot of women also take it to go into labor because as it increases the blood pressure, it causes the placenta blood vessels to rupture, and they get a clot between the placenta and the uterus. That's called an abruptio placenta, and they end up delivering early. But it's very dangerous. It causes baby can die. That's why it has an increased mortality, and also increased incidence of premature birth. All of that is fine. What's very interesting is the incidence of SIDS is increased by 4 times the general population. Okay, so to summarize, yes, cocaine does give you withdrawal, but more the concern that I'm concerned with is the long-term effects because it affects the fetus. It kills off their brain cells. It makes them smaller, and they tend to have long-term handicaps, learning disabilities, etc.
Could you move just a little closer to the mic?
Closer? Okay, sorry. I can't tell. I need a sound meter back there. Can't tell whether you guys can hear me or not. Just let me know in the back, okay? Again, what I basically said before, neonatal cocaine is not as clearly defined as opiates. When the mother goes through withdrawal, it's a whole different symptom than the baby getting withdrawal. She goes through apathy, long periods of sleep, irritability, depression, decreased appetite. The baby has some of the same symptoms, but they get a high-pitched cry, long periods of sleep, excessive sucking, decreased appetite, increased appetite. I got all this stuff from the Marshall Dimes. Marijuana. Okay, marijuana. Look at all the few names that it has also. I didn't know all those names. That was a learning experience for me too. That's more controversial, believe it or not. Some people think that it does not give you drug withdrawal. Some people think that it does give you drug withdrawal. But if it does give you drug withdrawal, it's certainly not very severe, and it's closer to caffeine. Also, the jury's out with respect, does it give you long-term effects or not? Some people feel that it gives you attention deficit disorder in the neonates. Some people disagree with that. So that one's not for example, cocaine is evidence-based, no question about it. This one, you can argue about it, okay? That wasn't me. This one is, this is a good thing. We're going to talk now about nicotine, and I figured I did this picture. What are you going to remember out of this? Nicotine gives you cleft palates, okay? A lot of people forget that. Babies also that go through they get intrauterine exposure to caffeine or nicotine tend to have a withdrawal. It's also not a real bad withdrawal, but they do have withdrawal, and sometimes they have to stay days over in the nursery. Important things regarding nicotine that's very well documented and is evidence-based. It gives you a smaller baby. It doesn't always, but it has way higher incidence, like 2-3 times the general population, of cleft lip and palate. and it also gives you a premature birth. We've had babies that actually, the mom, on retrospect, the baby is born and the baby's going through drug withdrawal the second day, and we're like, what the heck? What's going on? The mom denies it. We test the urine toxicology. It's negative. And we tend to make the diagnosis of caffeine withdrawal or nicotine withdrawal after the fact. When the urines are negative, the baby's having withdrawal, and then it goes away. And that and the mom denies that she's done any drugs during the pregnancy, but caffeine can do that. Antidepressants. Antidepressants is another thing that we can get drug withdrawal from. It's a very tough call on the obstetrician because what's he going to do? So what they end up doing is using the minimal amount of antidepressants that they can. That's what they end up with. It gives you withdrawal, and the symptoms are listed, but that's, the typical thing. One of the things that we have to watch out for antidepressants, it takes the baby blood sugar go down. One of the things we as doctors have to keep in mind when they get the withdrawal, and they don't with the other ones, so we have to stay on top of that. Okay, now we're going to talk about the big boys. There's opiates and opioids. Who knows the difference? If you read the slide, you know the difference. Opiate is natural, and opioids are synthetic. Okay, not a big deal. That's just a technical problem. Okay, they both give you neonatal, give you withdrawal. The medical uses of it are pain relief, cough suppression like codeine, Lomotil for when you have diarrhea. But the problem is that you get addicted to these things. Oh, I think I mentioned this. Let me go on to the next slide. Okay, this is interesting. Not this part, but how do we screen? We have a pregnant woman. How do we determine whether they're going to have a problem with drugs? The first thing we do is we ask them. And if they say yes or no, generally they deny it. If they say yes, we're clean. If not, we can always test the urine. If you really wanted to, which we never do, it has to be like a court thing that we have to do it, you can test their hair. But the lab requires about a minimum of 50 hair follicles, so it's a little bit torturous to get it. Okay, you have to pluck their hair a lot, so that's why we never do it. Also, you can test the nails, but it's less popular to do that. But on the baby, on the other hand, we have an advantage. On the babies, we can test the urine like everybody else. But the baby's metabolism is a little slower, so they tend to clear at a slower rate. So we have more of a window to pick it up. What we are very good at is anything like, for example, cocaine that gets metabolized in the liver has to go in the stool. And since babies don't stool, whatever gets metabolized in the liver goes in the meconium. The meconium is the initial stool that's black. I know you guys wonder why that stool is so black. It's because they don't stool and all the bile goes in there and just stays for months at a time. So it comes out looks like tar. But potentially when we test the meconium, we can go back up to 3 months prior. So a mom can do cocaine a month prior to the delivery, stop using it, walk in here, have a negative urine on herself, a negative urine on the baby, but we still can bust her through the meconium toxicology. It can go back up to 3 months. Usually it doesn't go 3 months. Usually it's a month or two. Okay. Also, we can also torture the baby and pluck his hair for about 50 follicles. I've never done that actually. Make the nurses do that. But what's become very popular is what I've seen a lot of flyers is now testing the cord blood. And I got a flyer. I heard there was some research, and I got a flyer about doing it, and I gave it to the hospital here, and I haven't followed up on it. It must have been a lot of costs. You know, it's like buying a flat screen TV when it first came out. It's expensive, and you wait a while, and then you get it at a good price. But that may be the future way of doing it. However, it doesn't beat the meconium. The meconium is very good in that it can go back a long time. Okay, and the public doesn't know that. All right. Methadone, our biggest culprit, is an opioid. It's an analgesic. The thing about methadone, for example, cocaine doesn't have a long half-life. This thing has a long half-life. You can take methadone, one pill, and it lingers in your body for a long time because it doesn't get metabolized right away. Okay, it has a long half-life. But we'll get into this in a minute, but by the same token, the babies don't have withdrawal right away. They don't have withdrawal the next day. They can have withdrawal up to a long time later, depending on the dose. What all opiates do, if they fill these receptors that are called the U receptors, and that would be a question for the doctors, a board question for the doctors. The U receptors, we only have U receptors in two places, the brain and the bowel, okay? Methadone does not make you high, doesn't give you euphoria. It just supplies your demand for the U receptors, but you don't get high with it. Benefits of, this is important, an important slide. The benefit of methadone is that it's been around for a long time. It's been studied over and over again. So we're pretty solid in what we say about methadone, unlike Subunex, that it's been around only for a few years. It's been around more than 30 years. You can give it orally to the mom. It's not usually a street drug, although it can be. Here's a big deal. It's been proven over and over not to be associated with birth defects like cocaine is. It also does not give you preterm birth. This is the reasons why methadone clinics give it to pregnant women, okay? It actually forces the mom to go get better prenatal care because she has to go get the methadone, and then, you know, they get the sonogram, the HIV testing and all that, so it improves the prenatal care. That's actually been proven. And she doesn't have to be doing whatever it takes to get her meds. I mean, she doesn't have to be a prostitute to get it. She can just go to the methadone clinic and get it. Those are benefits of it. The big handicap about it is that the babies do withdraw from it, and they withdraw really good, okay? It's a bad withdrawal. And it's tricky also, like I mentioned before. It doesn't have to be the next day. You can probably say average onset of time is like on day 3. Subunex, which is the new drug, also fills the U receptors, not as well as methadone, but it does. From the adult side, it's more expensive, and the movie stars, when they go in one of those centers, they get this stuff. They don't get the methadone. So from the adult side, they like it. The doctors like it better for the withdrawal. No, from the pregnant side, it's the same. It's the same. If you ask the nurses, it's worse. Okay. The definition. What's the definition of neonatal abstinence syndrome? We used to call it drug withdrawal. Now the name is changed to the neonatal abstinence syndrome. A generalized disorder presenting a clinical picture of central nervous system hyperirritability, gastrointestinal dysfunction, respiratory distress, and vague and unnormal symptoms. And these are them. Let me not go through them. What I want to make a point about is that, remember those U receptors that I talked about? They're in the brain, and they cry and they go crazy, but they're in the bowel too. So they go through a lot of GI problems. They vomit, they poop. They tend to get awful diaper rashes because they poop every few hours. I actually had to use Domotil a couple of times on the babies because you have to give it a break because the rash, the skin comes off and literally drip blood. So I have to come and get creative with it. But by the same token, aside from the diaper rash and the cramps and the diarrhea, since their GI motility is so fast, they don't gain weight. So a lot of times we have to give them premium formula, higher calorie and higher quantity, because they're consuming a lot of calories in their withdrawal. Okay, it's like, getting an athlete running a mile every day, they need a higher calorie intake than the average person. This is important, somewhat important. All these drugs have a different onset of symptoms because they're all different. The average onset of symptoms for methadone is 24 to 48 hours, and I would say it's closer to 72 hours. I would say it's closer to the 72 hours draw, which is a little bit of a problem because a lot of times these babies get discharged home at 48 hours, and they don't have withdrawal, and they come in the emergency room seizing, which is something I'm trying to push the pediatricians not to be too quick to send these babies home. But there's still the common practice is they send them home, I'll see them at the office, whatever. Okay, but they don't go to the office. They don't want to get busted. Heroin, however, gives you, heroin gives you a very short, it gives you a good withdrawal too, but it's less commonly used, but it gives you a very short onset. The onset is very quick because it's not a fat-soluble drug. It's water-soluble, so it doesn't go in your fat cells, so when you miss it right away. Opiates, up to 14 days, which is methadone. Cocaine, up to a week, but it's usually at 48 hours. Alcohol, right away. That's definitely water-soluble. And Subunex, same as methadone. It's something interesting that you guys are gonna catch interest, feel it's interesting. Who's more likely to have drug withdrawal? A term baby or a preterm baby? Take a guess. Right, the term babies will have it more. We don't know why, but the postulation behind it is that their neurons have more synapses, and more U receptors, so they're more likely to. Right now we have twins up there that they're methadone exposed, but they're so tiny, they're good. And the same baby that were term, they're more likely to have a withdrawal. So preemies tend to have less withdrawal. The onset of withdrawal also has to do with the quantity of the drug must be taken. It's a whole difference if the mom is taking 35 milligrams of methadone or she's taking 400 milligrams of methadone, as far as when the withdrawal happens. The duration of the intrauterine exposure, the timing. Maybe she took the last dose of medications a week before. If she took it the day before or the day of delivery, they're going to have withdrawal later on. So all those things have to be taken into account when they have the withdrawal. And by the way, people are very variable, even the babies. Some babies don't have all the rights in the world to have a withdrawal, and they don't. And some babies do with 35 milligrams. I've seen that happen too. So bodies are variable too, although there may be factors that we don't know about. What percent of this is term babies. What percent of term babies withdraw? The answer is 50 to 95%, because the problem is a bunch of authors that put different numbers. So I took the upper range and the lower range of those numbers. Not all babies that are drug exposed have withdrawal. Okay? So as you can see, some people would argue 50% of them don't. Again, touching back in this thing, the methadone particular babies or the Subunex late withdrawal, it's been reported up to 4 weeks. Okay, let's say the mom was taking 400 milligrams, which was a humongous dose of methadone, and she took it the minute before delivery. That baby's going to have methadone in his body for a long time, so it's probably going to walk out of the hospital without having withdrawal. The recommendation from the Academy of Pediatrics from February of last year by this author named Mark Hudak was that babies are methadone exposed stay in the hospital for 5 to 7 days. And this is a policy of the Academy of Pediatrics, right? And they should be monitored. And they also have different durations for different drug exposures. For example, the heroin doesn't have to, believe it or not, the heroin doesn't have to be washed out long, but the methadone does. Once we start the treatment of neonatal drug withdrawal, it's not always morphine. The first phase of the treatment, just putting the baby in a dark room, in a quiet room, and having people hold the baby. I'll get into it in a minute, but in a specific C position and hold their butts in certain ways, select to be their butts to be held, and sometimes that's enough, and they don't need pharmacologic treatment. Okay. I wish we had volunteers that would come do it, because the nurses don't have time. They get assigned, let's say they're in the drug room, there's one nurse for 4 babies, and there's no way she can hold all 4 of them at the same time. I'm actually pushing the hospital just to get anybody, I don't care who it is, that wants to volunteer their time to hold babies and keep them from the meds. Because the meds work too, but then we have to expose them to morphine. Regarding the feedings, which we touched on before, the trick is to feed them frequently, high caloric, usually premium formula, if they need it. We actually watch the growth curve. If the growth curve starts dropping off, then we start getting fancy. We start frequent feedings with premium formula, high calorie formula. More volume, which is no problem. They have frantic sucking. Usually they'll take more by themselves. Also, once we have them in the hospital, we like to test for comorbidities, such as HIV, hepatitis C, stuff like that. Hepatitis B we can't do anything about, but HIV we can. Okay, we can, we can make a big difference in HIV. Sometimes, like that baby we saw in the video, you're going to try to feed that baby. He's not going to want to eat. They need an IV. If at the very least, we need to put a tube in their stomach and feed him like that, because he's not going to want to eat until we get the withdrawal under control. Oops. Oh, breastfeeding. What's the recommendation of breastfeeding? You have a mom that is taking 400 milligrams of methadone, and you know the methadone is going to come on the breast milk, and the baby's going to be exposed to methadone. Should we breastfeed that baby or not? The answer, to my surprise, when I did the literature, is yes. For 2 reasons. One is it tends to decrease the amount of pharmacologic treatment for the baby. Also, we are aware that some of the methadone will go through the breast milk to the baby, and the answer to that is, so what? So they'll get medication like that as if we're in utero, and they'll wean off of it easier. So the answer is from the Academy of Pediatrics is a yes. The only thing that they say is, if she's breastfeeding, don't stop suddenly. Don't say, if she wants to breastfeed, okay, fine, breastfeed, but don't stop all of a sudden, because if she's getting the pharmacologic treatment through the breast milk, don't do it suddenly. And actually, an Australian study that we have here showed that they're less likely to end up getting meds if they get breastfeeding. I had to look that up. I had to look up the breastfeeding, because it looks like you don't want to do it because it's uncontrolled, the amount of medication you're giving to the baby. But the recommendation of the Academy is yes. Okay, now we have a baby having drug withdrawal. What are we going to do to quantify the withdrawal? What are we going to do? Well, what most people use is called the score system that's called the Finnegan score, which I have a slide of it coming up. It actually lists all the symptoms and gives a number to them, and it tells you how bad they're withdrawing, and it gives an objective number, how to treat, how much to treat, etc. However, it's not very universal. Only 65% of units use the Finnegan score. Other people use the Lipschitz score, which I never used in my life. Some units develop their own scores, and some people don't use any scoring system at all. They just give them medicine according, let's give point something. Okay, and I wish it was all Finnegan score or whatever system, but as long as it's the same place, yeah. This is the Finnegan score. You know, it basically has all the symptoms that they have. It gives you a number, and the nurses come by, and it's actually in Cerner. You know this computer system we use here? It has a Finnegan score. It has a Finnegan score built in. They call it the NAS score, but it's this. And it has the numbers, and you give a number to the baby, and then at the end of the day, at the end of 24, usually I come by at the end of 24 hours and look at the scores. I look at the average, and I decide whether to go up in the medicine, down the medicine, what the heck. All right? What I mentioned before, the non-pharmacological treatment of it is important, not to be forgotten and jump to drugs immediately. This has been evidence-based to, all these things have been evidence-based to decrease the amount of medication. So if you put them in a dark room with little stimulation, low lighting, you rock them, and you have somebody holding them in a C position, hold their butts like they like it, a lot of times they go through withdrawal without the need for medication, okay? You know I didn't do that, right? What do we treat them with? I think the majority of people use morphine. That's what I tend to use, morphine. And those are the doses, and that's the schedules. Other centers don't use morphine at all. They use methadone. And other centers less often use clonidine. One medicine that's not mentioned there is phenobarb. Phenobarb is complete different medicine altogether. It's not a replacement medicine, it's a substitution. And what I tend to do is I tend to use the phenobarb on a PRN basis whenever necessary. So I start them on a medicine like whatever, and if they're having withdrawal and they seem to avoid going up on the morphine, I give them phenobarb. And phenobarb is like methadone, lingers in your body for 48 hours. So that holds them off for 48 hours, and then I don't have to go up on the morphine because, you know, I don't want to get them addicted to morphine also. Okay. This is the references of all this stuff that where I got all this information from. Great. And thank you.